everyone. Good afternoon, everyone, and welcome to this hybrid meeting of the Integrated Joint Board. I would remind all attendees that this meeting is being recorded and webcast live on the Council's YouTube channel. I've agreed the attendance of some members remotely and would remind all remote attendees to mute your microphones when you're not speaking, please. And for any members of the public watching, please note that all the public committee reports, including details of specific recommendations, are available on the Council's website. At this point, I would refer members to item 3A, the minute of the IJB meeting on February 26th. As members will be aware, this has not been sent to members in line with the required 5 clear days before the meeting. However, it is an item of business as detailed on the agenda in accordance with the provisions of Standing Order 3.5. As chair of this meeting, I determine that this item can be considered. And also in relation to item 5, we would suggest that we hold that paper over for a future meeting and consider it in due course. Is everyone happy with that? Marvellous. And also, I have left my indoor glasses in the car and only have sunglasses. So everyone is a bit fuzzy. I apologise, but I've got people looking out for hands and wave visibly. I'm not into subtlety today. I just need to be able to see you want to speak, okay? So thanks for that. I'll probably not do it again, but that's where we are today. Okay, so on that, could we please have apologies, Liz?
Thank you, Vice Chair. We have apologies from Stephen White, Chris Boyle and Hayley Mearns and Leslie Sharkey.
Thank you very much. And as you'll be aware, Steve's apologies have resulted in me being in the chair again today, so apologies for that. Declarations of interest and statements of transparency. Has anyone got anything for us to record? I'm not seeing anything fuzzy or otherwise. Okay, thanks very much. Hello, Martin. Come away in, we've just started. Could we then move on to item 3, which is the minutes of the previous meeting? Are there any factual inaccuracies that need to be corrected, or is everyone happy to approve those? Happy? Yep. Thank you, Sam. Okay. And could we move on to item B, the action log? Jill, thank you.
Thank you, Chair. I'm actually just going to hand over to Sandy and David Coulson to provide an update on the action point. David first.
So David first, please. David's online. Thanks.
Thank you, Chair. So just to say, there's been ongoing debate between members of PMG regarding the affordability of new medicines. I feel it's important to emphasise that the existing medicines governance infrastructure in Tayside is strong, clinically driven, and underpinned by well-established and effective processes. Our structures have consistently delivered safe, clinically effective, and cost-effective outcomes for patients. They've allowed us to navigate increasingly complex therapeutic, regulatory, and financial environments while maintaining patient-centred decision-making. We also recognise that the landscape is shifting. The clinical complexity of care, national direction of medicines policy, and pressures on healthcare funding require us to ensure that our clinical practice remains contemporary, evidence-based, and sustainable. In this context, the ongoing review of the Area Drug and Therapeutics Committee, initiated through the recent stakeholder event, is a critical part of our future positioning. We've agreed to meet ahead of the June PMG meeting to further explore the challenge of affordability, and there was comments about escalating to the Director of Finance this morning too. So that's my statement in regard to this action, Chair.
Thank you, David. Appreciated. And Sandy, did you have anything to add to that?
No, nothing specific, Chair, but I echo the comments that David's made. These are difficult issues that we're trying to deal with, and I personally will be happy to contribute to discussions that are regional discussions. Thanks.
Thank you very much, Sandy.
Thank you, Chair. Again, it's just to ask members if they are content with the June date 25 with a view to, based on what both David and Sandy have advised, then we will aim to close that off in the June meeting.
Yes, I think we're happy to do that, David. Thank you very much for your contribution on that. Having been involved in discussions at NHS Tayside as well, I am aware of the complexity, and it's not just Tayside that's contending with these issues. Thank you very much. Okay. And if we can move on to item 6 now, which is the Chief Officer update. It's over to Jill.
Thank you, Chair. And just to reflect on the agenda, we did have a service user story which we have deferred. The service user story itself was in relation to the mental health and learning disability update. That update paper is due to come in June, IGB, so we will bring that service user story forward for that report. So members will have in front of them the Chief Officer update. I think the report itself is detailed enough, so I won't go through it in detail. Just to pick up on a couple of things, I did mention at the February IGB in relation to the resilience management processes and in particular the South Grange incident. So we have now had our debrief on that with identified learning, and we are contributing to a multi-agency debrief. And Chair, I would just like to extend my thanks on behalf of the executive management team within the partnership for all the work that the staff did in relation to that incident. The other things to pull out is in relation to the visit that we had from Gregor Smith, the Chief Medical Officer, a couple of weeks ago in Montrose. He attended, and the representatives from across various services within the partnership were able to share some of the work that we're currently doing around prevention and proactive care, along with our colleagues in Angus Alive, to share some of the exercise classes that was also interesting. However, the feedback from that was immensely positive, and he has written a letter of thanks. So just to raise that in terms of members' awareness. Thank you.
Thank you. And I think we ought to thank Sally for her role in pulling that together as well, and taking the opportunity to invite the CMO when you were at the Realistic Medicine Conference. If you don't ask, you don't get, Sally, so more power to your elbow on that one. It was a fantastic session, and don't be surprised if you see Angus reflected in his annual report, which is being written as we speak. Any questions to Jill on her? David?
Beg your pardon. At the last board meeting, I'd asked if information around respite care, both its availability and use, would be included. And is there a problem about that?
Apologies, David, an oversight on our behalf, but we will get that information to you.
Thank you. Lois?
Yep, thank you. I just wondered if you could confirm in relation to the unmet need. I noticed in 3.1 that under the learning disability delayed discharge, there is 6, which is always, concerning. I just wondered if those figures had been incorporated into the unmet need, and also if you could just provide an update and some assurances with regards to the issues that Angus experienced in terms of community alarm and the analogue to digital network issues. Thanks.
I'll hand over to John for the unmet need, and then Eunice for the community alarm, if that's okay.
Thanks, Jill. Thanks for the question, Councillor Speed. So just so I'm clear, in relation to unmet need, obviously we do have a good news story in terms of the overall number of hours that have been reduced, and that's through a lot of hard work from the teams in terms of reviewing plans, but also in terms of opening the tender for option 3 providers as well. So we're seeing the kind of numbers drop overall as a whole. In terms of the delays within transfers of care, it's quite hard sometimes to relate that necessarily to unmet needs. Some of that might be about a lack of resource in the community that can contribute to delays. So in terms of the 6 that are identified from our learning disability perspective, I would need to obviously get some more information around that and see if there was unmet need contributing to those delays. It could be a whole host of reasons in terms of complexities around legal status, etc. So I think it'd be difficult to comment really on those 6. But overall, we are seeing a much improved picture as far as levels of unmet need go in Angus, but happy to look into those specifics for you.
I would just offer some reassurance around the 6 and learning disabilities. It's very complex and there is a lot of work getting done to look at resources, providers for that cohort of people. So there's a lot of energy going on around that. Obviously, because it's small numbers, I don't want to go into too much detail, but I can give you assurance that there is a lot of work getting done to address the issues for these people and make sure that we get the right resources for them in due course. Thank you. Sorry, yep, just stopped and then started again. So in terms of the community alarm situation, it was a national issue. So there was a national issue with the network, which impacted on Angus Community Alarm. So there was, which ultimately meant there was a delay in calls coming through. So people were still able to contact the community alarm system, but there was about, I think it was about a 10 to 20 minute delay. It kind of varied over the course of the few days that we had this incident. So what we did as a result of that, there was quite a lot of promotion on social media so that families and neighbours, etc., were aware of the issues. We also put in additional staff so that we had staff, in the various areas so that we could respond as quickly as we could, given we knew there was a bit of a delay. And by the Sunday afternoon, the issue had been resolved, and we were confident that nobody came to harm during this period and that everybody who needed assistance did get assistance. So thank you.
Thank you, Eunice. Thank you very much. Any more questions for Jill? No, we're just being asked to note this, so thank you for that report, Jill. Okay. Moving on to item 7, which is the updated annual work plan for 25 to 26, and again, that's Jill.
Thank you, Chair. Happy to just move to the recommendations. It's a fairly straightforward report that is an ask in relation to the development sessions for committee.
Okay. Any questions for Jill on that report or anything to highlight on the development sessions? Yes, David, and then Lois.
Thank you. I note that the day opportunities doesn't have a date against it coming back. It was previously, we were advised it was coming to this meeting, and nothing there. There is no further date nor explanation, and it seems to have been pushed back a considerable number of times.
Okay, thank you. We have been doing a lot of work with the current day care providers, along with our VAA reps as well, in relation to the day opportunities work. We're just in the process of finalising a timeline, David, to bring that back based on the concerns that were raised at IJB previously, and we are working closely with them to do that, so we will have an updated position for the next IJB in terms of a date. But I absolutely acknowledge the delay in bringing that report back.
Thank you. Lois?
Yeah, thank you. My question was actually the same, that I'd noted that over the last couple of IGBs we'd been referring to daycare review and a date for bringing a report back to this meeting. But now it's switched to day opportunities. And just for clarity, are you saying that a report will come to the next IGB with information, or just the date?
So the daycare review is complete, and that was the report that came to IJB August 24, and that was when we transitioned from the daycare review into day opportunities. So it's the day opportunities work that we've been working closely with VA, etc., in terms of third sector interface, and the current daycare providers. We will bring an update in terms in the Chief Officer report in terms of where we've got to around the engagement with them and the development of the framework. That is in draft format at the moment, and as I say, we're working closely with them to make sure that everybody is involved and we are collaborating on the development of that framework. So it'll be a date that comes back to the next one.
It'll be a date that comes back that will then, on that date that you're proposing, you will come back with a set of recommendations, a report and recommendations as to the way forward.
There'll be a full report come to IGB to consider.
And all providers are aware and know that it wasn't coming to this one, is that right? Just for assurances,
yes.
They're all kept in the loop?
Yep.
Thank you.
So if it's helpful, because I sit on the board of Voluntary Action Angus as well, I'm aware of the much deeper engagement that has taken longer because it's been much more intense, and I think it's been helpful. I think it'll be worth it in the long run. So I'm aware from that aspect that there has been a lot of engagement. So yeah, it's been worth doing, I think. That's why it's taken a bit longer. Okay, thanks. Okay. So, everyone happy with those development session dates as well? Fully appreciating that life is a bit of a moving feast and diaries can change at short notice, but that's lots of things to look forward to. So thank you for that. So everyone's agreed there. And it's now over to item 8, which is the finance report, and over to Sandy, please. Thanks, Sandy.
Thanks, Chair, and good afternoon, everybody. I'll just highlight a few points from this report and then happy to take any questions. This report is based on our February financial position. Literally, as we speak, we are still working towards finalising the final figures for the IGB's financial year end, so we don't quite have those yet, but they will be available soon. At this time of year, it's important I highlight some of the issues set out in bullet point 4.3 of this report. In these reports that come to the IGB, we are sharing management information. At some point in the next couple of months, members of the Audit Committee in particular will see a set of financial accounts reflecting a financial accounting position. And there are differences between the two that I've alluded to in this report, and that does include things like reserves. Much of the body of the report, Chair, particularly in section 5.5, reflects that a lot of the things we've seen up to the end of February were consistent with what we had been projecting earlier on in the year, so I'm not going to go into that in much more detail, but in section 5 I will just pick out a couple of points. 5.6.2 clarifies a position we reached regarding supporting the costs of inpatient mental health services across Tayside. A number of parties contributed to that agreement, and we agreed to develop a position through a variety of people, Chief Officer, Chief Finance Officer, and with the support of the majority of voting members. And I've set out in sections 5.62 and 5.63 where we got to in reaching that position. Another point in section 5 I want to highlight, because it does have an impact on us, is section 5.72, where we provide a further update about our use of large hospital services, in particular beds at Nine Wells. And you can see the trend continues there, and that we continue to use a slightly higher level of bed numbers than we have in previous years. Otherwise, Chair, I'd like to just move to section 7, where we summarise the position. Section 7.2 describes the high-level position that is consistent with what we've seen earlier on in the year, so I'm not going to go over it, but much of the messaging there is, as I say, is consistent with what you've seen projected at previous IGB meetings. And then highlight section 7.3 and 7.4, where we talk about how we would deploy some of that underspend, referencing back to previous permissions and devolved authority that we agreed back in December, and how we've chosen to take that forward, which is particularly set out in section 7.4. And I think, Chair, that's the main points I would like to highlight, but obviously happy to take any questions.
Thank you very much, Sandy. Nice and clear, as always. Any questions for Sandy on this report? Martin, thanks.
Thanks, Andy. And it's about the unfilled positions again, and it's seemingly hard. Is there a different strategy that can be used to try to engage in the unfilled positions start to be filled?
Thanks, Martin. Yes, so we have had a number of unfilled vacancies throughout the year. The number is obviously not exactly consistent, but it's been a relatively high level compared with what we would expect to have throughout the year. The issue of unfilled vacancies kind of almost sits next door to the issue of unmet need, and I think we've already commented on the fact that some of the unmet need levels have come down. But Eunice supports a lot of the workforce work, so I'll let Eunice come in terms of where we are in terms of filling vacancies.
Thank you, Sandy, and thank you, Martin. So just to offer some reassurance that we have a workforce steering group, and within that a number of subgroups, but one is on recruitment and retention, and we have a huge focus on how we can recruit staff and bring people in to work in Angus, and also how we retain staff, because that's equally important. We have a variety of actions that we look at on a regular basis. We've done work on how we want to recruit, so we've got video briefings now in place for people, so we can do videos. You'll see some of them are on our website. We've also done a lot of work with care providers, and we know that that has resulted in an increase in staff coming to work in our home care sector. So lots going on. We've also been quite creative, and we've got workforce reserves that we've used to over-recruit newly qualified social workers and nurses and an HP, so that we can bring in newly qualified graduates and bring them into the services. So a lot is going on. We're looking at international recruitment, and we have international recruitment in place. So lots of things happening in order to try and reduce the number of vacancies that we have. Thank you.
Thanks, Eunice. I wonder if it might be helpful for Martin to hear a bit about where those new recruits are coming from that aren't the newly qualified ones. But are we bringing new people into the sector, or are we moving people around the existing sector? So it might be a bit of robbing Peter to pay Paul, and I'm just concerned that, you know, it's not a deficit that we're creating elsewhere. Is it new people? Thanks.
So I think it's a bit of both. So I think it is some new people. Some people, you know, we do encourage succession planning in the partnership. So we do want people to move around, move up, you know, develop their experiences and skill sets. So that's not necessarily a bad thing. So we do that as well. We've got a succession planning framework that we have in place. So it's a variety of things. And we know that some professions there is a national gap. So no matter what we do, there is real national challenges around some of the professions that we require to meet all our services in Angus. So that's ongoing as well. So we are working with universities and colleges. We work with our parent bodies, Angus Council and NHS Tayside. We've got really good links with HR departments there, and we're trying to work together and be as creative as we can. So thank you. Sorry, just to add, the other thing we're really driving forward this year is supporting young people. So we're really keen to get young people into work with us and using the variety of schemes that are available, and that's a strong driver for our workforce plan, that we want to try and grow our own workforce and bring young people in. So that's something else we're also doing. Thank you.
Thank you, Eunice. Martin, was that helpful?
Very helpful on the modern apprenticeships.
Could you remember your microphone, please?
Modern apprenticeships is part of the plan. Also, there's been investigation into the vacancies to see if these jobs could be actually brought together or filled.
Yeah, so that's all part of our strategy. So we have jobs where we review every time there's a vacancy. Do we need that role? Do we need something different? Do we need a lower graded job? Can we do this? Look at skill mixes. So we do all that every time there's a vacancy to see what we need to do. Some roles we can do what's called a run through, and you can employ somebody at one level, and then as they get more experience they can move into another level. So I think we're trying to be as creative as we can with all these things. So thank you.
Thanks very much. That was helpful. Okay, so we have. Oh, sorry, Lois.
Okay, yeah. No, it was just to say, really, I respect, obviously, the majority of you on this report. However, just for clarity, I did raise concerns around Angus's kind of ongoing financial position and kind of year-on underspends, and also the gathering of reserves, which I appreciate the complexities and why often that is the case. However, I would like to see us move into a much more kind of when we actually are using our budgets. And I'd also highlighted as well during these discussions around the concern I have around CAMS, Children's Mental Health Services, and the change in service there, and the impact that that might have within adults' mental health services too. So I just wanted to kind of, for the record, put that, have that noted. Thanks.
Okay, and also I think it might be helpful, particularly for anyone watching, that when we return money back to our partner, our parent organisations, if you like, that money is being spent on Angus people as well. It's just a different part of the system, and you'll have seen from Sandy's report that the Angus usage at Nine Wells has increased. So it's not that our citizens are experiencing a deficit. They're still getting the care that they need in different parts of the system. And I had something in relation to your second point, and I forgot what it was. CAMS. So there's a recognition at NHS Tayside that the communications there were not what we would have hoped. So that is being addressed, and the new model will be properly communicated in due course. I think that's following further engagement. I think that's fair to say, probably. Do you want to come in on that, Andrew?
Yep, thank you, Chair. Just to give some reassurance and assurance that the CAMS is being actively looked at, or the difference between the mental health and the neurodiversity pathway is being looked at. There's both engagement across both health, education and social care going forward through TRIC. There's also a short life working group being established with some support from Scottish Government to look into this as well. And on a more practical level, in terms of communications to parents, there's a group of us looking at improved communications in plain English that can be understood by those parents and children that have currently been referred, so that they know where they are and have better information and better resources that they can be guided to. So hopefully that work will progress fairly rapidly over the next couple of months.
Okay, thank you. Yep, finally. Yep.
Yeah, just to say thank you both for your input. I think it can often be very difficult for the public, especially service users, patients, to see monies being handed back when they perhaps are struggling or not receiving the right supports or services. That can be quite difficult. I think for people to understand, and even as an IGB member, I struggle with that at times. And I think what would be reassuring is if in future we can actually see and be assured that monies that are handed back, albeit for the benefit of Angus residents within services in other areas of the system, it would be good to actually see that, you know, that has been the case and that money has been spent for the benefit of the Angus population, and that it hasn't just gone into the bigger, wider NHS service, if you like. It would be good to have reassurances that is the case. And thank you also for the update on the kind of the CAMS, children mental health and neurodevelopment situation. It really would be good to see improved communications on that going forward. Thank you.
And I have specifically asked that local authority councillors, all councillors in all 3 local authorities, are treated with parity in terms of communication, not just MSPs and MPs, because we're at the front end of receiving queries from our constituents. So looking forward to that being taken on board. Thank you. Okay. Okay, chip in.
I was just going to say we can include an update on the CAMS position in the next Chief Officer update, just for information.
Okay, right, so Sandy's paper, back to the recommendations there. We've been asked to note the overall projected financial position and accept and note the update on reserves in Appendix 2. Are people happy to accept those recommendations? Yep. Okay, thank you very much. And we move on to item 9 now, which is the strategic financial plan. So Sandy again. Thanks, Sandy.
Yeah, thanks, Chair. So, a strategic financial planning paper covering 25-26 and the 2 years after. Members of this group saw a draft version of this plan when we met at our February IGB meeting. This paper is an update of that, and the recommendations show that we're looking for it to be the output of this paper to be adopted as a position for 25-26. We haven't repeated all the content of the February report, where it remains largely unchanged. We have included a number of updates in this report, though. Some of the headlines, and I'll come to it towards the end, is this financial plan does still remain out of balance by the third year. In terms of picking up one or two highlights, section 5.2 talks about funding assumptions, budget settlements. There's a paper next on the agenda about a budget settlement with Angus Council. That was not an issue that was clear for us when we were putting together the papers for the February IGB. So the information at 5.21 and 5.22 is newer information. It's now all reflected in the overall plan that's summarised at section 7, with a couple of scenarios set out. So that is new information, and you'll be able to read where we are with that. Another item that is worth highlighting is referenced at section 5.3.3 under the cost pressures area, and that was about our approach to managing the issues associated with employers' national insurance contributions, which again members of this group might remember was the subject of a bit of discussion last time. And we said we would come back to the board and describe where we'd got to or where we were going with that, and that is summarised in Appendix 3. There's a page of documentation about where we are. Hopefully that's helpful. In terms of other points, I would then probably take us towards the summary sections. Section 7, the overall financial implications. There are a couple of tables, 5.2 and 5.3, describing scenarios based on the budget settlements. But most, I suppose, relevantly in terms of a summary position, Table 4, again within Section 7.4, summarises the financial position as we are describing it at the moment. Just to summarise this for everybody in terms of words, I'm going to focus on the recurring column, because we are here to make strategic decisions. We obviously have to manage an operational position and a position in 25-26 and 26-27, but looking at the longer term, our headline shortfall is about £12 million. We have already signed off on a number of savings plans that we have to still deliver. They were worth about £3 million, largely discussed at the IGB in August 2024. That brings a shortfall in 27-28 down to about £8.5 million. In the next few years, we still expect there to be some non-recurring savings and underspends. These are more likely to contribute to the plans in the earlier years than the later years, and you can see how that might contribute in 25-26 and 26-27. I will say, though, issues like a reduction in the level of unmet need or a reduction in the level of vacancies, which is all what we aspire to, they will, offsettingly, mean there aren't as many non-recurring underspends as we have seen in the last couple of years. Getting the balance of that right in terms of being overly cautious or whatever, I'm not going to say optimistic, but overly cautious in terms of us sharing a position with you is difficult. But if we do fill vacancies and we do have lower levels of unmet need, these numbers will change, and board members will be familiar that these underspends have been a feature in the last couple of years to the IGB's reporting. The other factor that contributes to our position in the short term, in the next 1 or 2 years, is our ability to still use some IGB reserves, and you can see that on the second bottom line of the table, table 4, that they will help us support our financial position in the first couple of years. But what they don't do is they don't resolve the recurring or the underlying or the strategic financial shortfalls. And it's obviously the job of the IGB to help close those out and make strategic decisions to help us close those out and deliver our strategic commissioning plan on a sustainable basis. In terms of delivering that, section 7.6 describes one of the actions that we've already taken, because in February we already agreed to ask our executive management team to bring back a series of proposals to the June IGB, which I know the executive management team is working on. Final point I'd like to make, Chair, refers to the risk management section. The very first line of that, in 8.1, notes that we're producing this financial plan against a backdrop of significant uncertainty and unprecedented levels of risks. The list of risks is set out in Appendix 2. It's a long list. It's a complicated list. These risks generally only go one way, and that's go against us, with more problems coming into our system. A number of them are unquantifiable at this stage, but board members should absolutely keep in mind that list of significant risks that we will have to manage over the next 1 to 3 years. And I'll stop there, Chair, but I'm obviously happy to take any questions. Thank you.
Thank you, Sandy. And I'm aware of the enormity, the work that you've put in to this. Appendix 1 is tiny, it's really hard to read, but it's difficult getting it all on the page. And I'm also very much aware that the Angus Health and Social Care Partnership performance in terms of service delivery and financial management is very well regarded in government. And I just wanted to reflect all the work that you've done has not gone unnoticed, so thank you for that. Any questions for Sandy on this paper, please? No, I'm not seeing any hands. Any comments? No? Okay. Just go back to the recommendations then. And we're being asked, I think, sorry about swithering back and forward, consider this version of the Strategic Financial Plan and approve the adoption of the 25-26 position as an interim financial planning framework. Okay, everyone happy with that? Thank you very much. And thanks, Sandy. Okay, and now number 10, the budget settlement. Thank you.
Yeah, thanks, Chair. Just to, again, place this paper in the context of what we would normally see coming to an IJB. We would normally expect to see budget settlement papers coming to the IJB in February of each year, and that's what we've managed in most previous years. There was more uncertainty in the system this year, and some of that was related to issues such as national insurance and how the government was dealing with that and how councils and health boards would be able to deal with that. So this paper is about the Angus Council budget settlement. Come on to 1 or 2 details in a second. There is a parallel issue about settling our budget with NHS Tayside. As referred to in the last paper, there are 1 or 2 uncertainties about that, and we are still working those through and in communication with NHS Tayside about that. So I expect to see a paper about that at our next meeting. But this sets out where we are in terms of a budget settlement with Angus Council. The proposal set out in here has already been considered and supported by Angus Council at the end of February or the start of March. I can't remember the exact date. The money is quantified in section 5.3. I hope that's clear to people. It shows an audit trail, if you like, from where we were at the end of last year through changes that have happened last year and then adding on various adjustments in this year. Important points to note are at section 5.4 and just beyond that. Helpful additional funding to support a helpful increase in the adult social care minimum wage to £12.60. That will be useful for recruitment and retention issues. Some funding to support employers' national insurance, but not as much as we would have wished, and not as much as will allow us to support costs in the independent sector in terms of people that we are working with. But that was referred to in the last paper. Ultimately, there are elements of this budget uplift which is largely driven by Scottish Government directives that are less than a real terms increase, and a lot of the pay costs are not uplifted. So that is a challenge for us. It's all built into the last paper in terms of the financial planning paper. And I've already referenced national insurance risks and issues in the last paper, but the budget settlement issue is effectively our funding side of it. The financial plan covered the cost side of it. So this paper kind of crystallises that we are obviously having to manage a new risk from this year in terms of the national insurance issue. But it's already allowed for the financial plan that we looked at a minute or 2 ago. So, Chair, that's just the main points. But again, I'm happy to take any questions on this.
Thank you very much, Sandy. Any questions from Martin?
Thanks for the paper. I'm just curious that the settlement is 78 from Angus Council. Pro rata, what would the expectation be then NHS Tayside? What is the split? 10% splits? And if that hadn't been forthcoming, because I find it strange, I've always found it strange that they kind of get one settlement that we're still waiting on NHS Tayside.
Okay, thanks, Martin. The two settlements are separate, and we manage them separately.
Yeah.
The two settlements are separate, and we manage them separately, and our partners obviously manage them separately with us. For example, this proposal that you're seeing today has already been reflected inside 4 more reports have gone to an Angus Council committee meeting, I think at maybe the start of March. The NHS Tayside budget settlement will be separately dealt with through NHS Tayside. So they are two separate routes that we have. That's just the way the IGB is funded from the government, largely through the two parties, if you like, to the integration scheme, and then through to us. The government does issue an element of, I'm not going to say directions, because I know we use the word directions in here, but they are specific about when the government give money to councils and health boards, they are sometimes quite specific about how money should then be passed through to IGBs and from the two parties. But the two things often will happen at about the same time, but not always. The history, so I'm maybe going into too much detail, but the council budgets have always tended to be settled quicker. And that's probably because the way the government settle funding with councils is quicker than the way it settles funding with health boards. The health boards have more incremental funding streams coming into them throughout the year that make that budget settlement from the government to health boards a wee bit more complicated, and therefore settlement from the health board to us is a little bit more complicated as well. It's a bit more straightforward in terms of there are less numbers in play on the local authority side. So hopefully that gives you an understanding of why they're separate and why we deal with them separately.
Microphone, please. Martin, microphone, please.
The risk that's associated with the funding, and if the NHT side then decided, and we didn't have sufficient funding, is that a 60-40 split, a 70-30 split, is that a 55-45 split? I don't understand that's what I'm trying to get at. What is the split?
The split is 38%, 62% roughly. But it's not a fixed percentage, so it does change over time. So those separate budget agreements that we have with the two parties could incrementally change it over a series of years. But it's not, we will always put in 38% and you will always put in 62. It's about 38, 62 right now. And sometimes money will come in through the health board to support social care services, but it will still come from the health board. So there's sometimes money has to move from one area to another. But it's not fixed percentages, it's fluid and it's moved over the years. Hopefully that helps.
Yeah.
Yep.
No, I'm just trying to get to that stage. What was 62-58? I know it's no tablets of stone, but it has to be, because if the risk comes in then and one of the partners, they're both supposed to pay for the risk. And if one's no paying, or didn't have funds to pay that, how do we go about, where is that risk gathered?
So at the moment, I mean, this is quite complicated areas, and there's maybe not a simple answer to your question, because maybe we haven't ventured into some of the territory that you're talking about. As a partnership, so far in the last few years, we haven't been in a position where we're overspent, and therefore the funding contributions that partners have given to us in any given year have been sufficient for us to run the services. If we get into a situation where those funds are not sufficient to help run our services, we do have there is a paragraph, or a couple of paragraphs perhaps, in the integration scheme that determine how the partners would potentially have to contribute additional funding to the partnership. There's also paragraphs in the integration scheme that determine what kind of remedial action we would have to take to try and solve that, to make sure it didn't become an escalating or exacerbating issue in a year or over a series of 2 or 3 years. And that does include things like changing our strategic commissioning plan as a backstop to try and ensure that we can deliver services sustainably. Before that, it also includes things like using local reserves to help support a financial position. So some of the things that you're just expressing a concern about and wondering how they might work out, there are things in the integration scheme that describe the first 2 or 3 steps that we would take that should cover most permutations of what could potentially happen. But it's quite an involved issue, and if it's something that either Martin or a broader group would want me to speak about again, I'd be happy to do that.
So I was going to come in there and suggest that we move up the development session on the financial aspects maybe a bit sooner on our schedule. And it might be helpful to have a wee bit around how the council's budgets are allocated as well in terms of the COSLA. So COSLA is the main negotiating body, and there's quite a raft of criteria. So your funding, each council gets their funding on the basis of different criteria as negotiated through COSLA, and obviously that includes levels of deprivation. So, and in the health service, there's a model called NRAC that is utilised as well. So they're different, but they're all kind of aimed at teasing out the same issues so that councils and health boards get the right amount of money. So it might be helpful to include some of that to help get everyone on the same page there. Does that sound like a plan, Martin? Would that help? Yeah.
I do understand that.
So,
I understand that. I was just trying to get the percentage in my head to fully. I fully understand the processes. What I always comment on for an integration scheme supposed to be across Scotland, but you've got councils and health services set budgets at different times. And I just find that fascinating that we call it integration.
Yeah, and that's what we're dealing. That's what we're dealing with, really. So, yeah, absolutely. Okay, Sam.
Yeah, Chair, let me just respond further to the timing issue, Martin. We brought a draft financial plan to our February meeting, and we've brought an updated plan here to April. So although we had lots of uncertainties at February, and things are uncertain, we're not sure about them, we were able to make relatively good judgments about them. And although we haven't kind of completed all the budget discussions with the NHS side, we are able to still bring a level of, I think, comfort forward when we're setting out a budget position. So we're always making estimates about our cost base, but we do have uncertainties about our funding base. But it doesn't mean we can't make an okay judgment about them. And I would feel, even if I'd written the budget paper in December, I'd have been able to have a good judgment about what kind of funding levels we had coming in. In February, we had a good judgment, but we've been able to refine it by the time we got to April. So we are able to make okay, reasonable judgments about the level of funding we have coming in, and therefore able to put a plan together. We're just not certain about everything. Much the same as there are all the certainties in the risk section, there are many cost uncertainties that we have as well. So even though we don't know everything, we are still able to make an okay stab at this is a reasonable representation, I think, of where we might be. But there are, and I said it when I was mentioning the risks, and you'll know it as well, there are a lot of uncertainties in the system right now, more than there probably ever have been. So we just have to watch those unfold over the coming months. Okay.
Thank you. And you'll be aware from the NHS reform and renewal plans that this is all about deepening that integration. So, Lois.
Yeah, thank you. I just wanted to kind of say that I think Martin raises really good points, and it certainly does feel over the years that from my kind of memory, at budget time, it did used to feel clearer and more together, albeit maybe the settlements were coming in at slightly different times. And there was always that kind of, push towards February, March time where there was still uncertainty. But it did used to feel like we would bring a report that was on the budget and the settlements. Whereas over the last year or two, especially this year, it does feel like it's much more fragmented. And the reporting feels a bit more fragmented. So that would certainly be something that I would be keen, and I know that, like you described, some of that's out with your control, Sandy, and if that's the way the funding streams are coming from Scottish Government down to NHS, down to ourselves, and you're not, in control of that, but I definitely feel that there is a shift and a change in the way in which the budgets, which isn't helpful for Angus or for yourselves in being able to, set your budget plan for the year ahead.
Yeah, thanks, Councillor Speed. You are right. Things have got a wee bit more complicated. And the single example, I'm just going to use the example of national insurance. It was very much a live issue. We all know that from the discussions across the country in various sectors. It was a new thing. It was a one-off thing. Hopefully, and it was quite uncertain. There's still a lot of political debate about it, and it was there was uncertainty between the UK government, the Scottish government, and the Scottish government and councils and health boards, and therefore with us. And we are almost at the receiving end, at the bottom end of that chain of decision making. So things like that do make life more complicated. We can't magic our own certainty about that. We were on the receiving end of that. It makes it more complicated for us bringing this stuff together. It is more time consuming. We sometimes have to come back. It does make it more disjointed because rather than having it all lined up in February, it has had to be drip fed. So to some extent, when we brought draft papers in there, we've had to make these judgments I was speaking about a minute or two ago. That's the reality. There are more factors kind of coming in that just kind of almost unsettle a potentially stable position, but they are out with our control. Yeah, but yeah, it's fair.
Yeah, it's caused problems for everybody really in the system. Yeah.
And how can Angus IJB, how can yourselves, I guess, feed back that message to Scottish Government or through NHS around, you know, the more pressing issues that we have, the more demand on services, the more, you know, the growing need that we know is there. I guess that needs an even kind of more better, robust way of being able to manage our finances. So how do we feed that message back that actually the way in which this is now fragmented isn't helpful? Because we don't want to just be taking a stab when, and I know that that's the best you can do, Sandy, and I know that you would make a good one at that, but it's not helpful when we've got so much pressing need, if that makes sense, and uncertainty within our communities.
Okay, thanks, Councillor Speed. I'm making a stab at it. It's not a technical term. If I use it, I will withdraw it now. So we spend a lot of time trying to put those together, but we also are trying to access national information as best we can. And sometimes the Scottish Government do share preliminary planning information. It's just not certain yet. Through all the finance networks, and I'll maybe pass on to Jill in a second in terms of the Chief Officer networks, we are regularly passing Chief Finance Officer feedback back through the formal channels that we have to the Scottish Government about being more certain about things. Sometimes it's about having a multi-year plan. That's really difficult because of the uncertain economic climate we're in. Sometimes it's actually really about being certain about the funding for individual programmes of care, because there are programmes of care that we see in these papers, not necessarily today, in fact, in the primary care paper, where sometimes we get funding one year after another. Many people around this table will have been on experience about having to deal with 1 year funding after another for 5, 6, 7 years. And we will often pressurise the government, can you just be more certain about that and be more clear, you know, on a permanent basis. So we do all that. Separately, in terms of the overall pressures, I know you weren't particularly talking about, you talked about clarity. Through the Chief Officers Network, we have been trying to engage as well as we can collectively with the government to kind of just set out some of the pressures that all health and social care partnerships are facing, and constructively putting that into national discussions with directly with the government.
Thanks, Sandy. Just to add to that, so there is lots of discussions that have been happening with CABSEC and with the COSLA leader as well, and they happen actually on a weekly basis, and finance is usually discussed at those meetings, and the impact of the allocation of funding with whether it's coming to health or social care, social work, and how can we do that better to make sure that we can ensure that the money is going to the right places. I think the Audit Scotland report just reflects the position of the IGB finances across Scotland. So there are continuing ongoing discussions, and I also know that it is raised through the IGB chairs and vice chairs network as well, which Julie may want to add.
Yeah, I was party to that letter from the IGB Chairs and Vice Chairs network, and I've been in meetings and directly raised that with the Cabinet Secretary as well. And I know how much work went into negotiations with the UK Government around increasing the level of support around ENICs. So at all levels, there is engagement, and it's constantly been raised. And also through my role in Public Health Scotland, I've been able to, raise the issues around fragility with the IGBs and impacts of changes in NHS or local authority funding, and the potential to impact on throughput, if you like, of patients when government issues new targets for us to all achieve, if that has a knock-on effect into the health and social care partnerships. So those are issues that I've been able to raise at a number of different levels, as well as the officer contributions in their networks. So it's not that it's not there and being heard. Okay, thank you. So on that basis, can we then look at the recommendation and accept the proposed budget from Angus Council contained within this paper? Thank you very much indeed. And item 11 is on to Alison Clements, Dr Clements, Sandy gets a wee rest there, around the clinical care and professional governance assurance report. Thank you, Alison.
Thank you, Chair. So you have the report in front of you. As ever, it describes our approach to clinical care and professional governance in Angus, which is very much following a quality improvement and quality management system approach. You'll see the three main risks highlighted there, which are the mental health risk and GP sustainability in Angus, and the failure to deliver the ambitions of the Angus IGB Strategic Commissioning Plan. And that's very relevant to the previous items on finance. We've also got the positive mental health report, good inspections at Rowan and Willow wards, and a bit of a description there around some of our quality improvements, particularly a focus on prevention and proactive care. And also I would like to highlight this is aligned with the Tayside clinical governance framework that has been recently endorsed in NHS Tayside. So we're very pleased that we've got the good links there. The report proposes a reasonable level of assurance regarding the risks presented in the report. However, the individual risks highlighted within the report are outline limited assurance. So it's just to be clear that we feel that with the range of work ongoing overall for the risks, that a reasonable level of assurance is being offered today. Happy to answer any questions, and you've got the recommendations there as well. Thank you.
Thank you, Alison. Just before I open it up, I have a wee question, so I hope I can sneak in there. I really appreciated the reports from the Mental Welfare Commission into Rowan and Willow, and I've picked up on the valuable role of healthcare assistants in one of the reports, and I just wondered broadly how the care provided by healthcare assistants is captured through the multidisciplinary teams, and is there something that needs to be done to improve that, or to engage healthcare assistants in those teams directly? So, Karen, if you can help,
Yeah, thank you, Chair. Happy to. Just for members' information, within a ward environment, there are what we call daily huddles. These happen several times throughout the course of a day, where all members of the team, the nursing team, are involved. So there's opportunity to go through the record and contribute to the record at that time to give information about an individual's care and treatment. Obviously, healthcare support workers are very valuable members of the multidisciplinary team, and we want them to contribute. But we have picked up in Angus, it tends to be the staff nurse that inputs directly into the record, and we want to have a consideration around how we might facilitate directly inputting the healthcare support worker inputting directly into the record, if that seemed to be appropriate.
Great, thanks very much, Karen. Yeah, and if you could reflect back the value of the roles that you know, the level of care that's provided in those wards, that would be really great. It was really good to read those two reports. I see Chris has online has got his hand up. Chris.
Yeah, thanks, Gavina. Just a quick question on the Angus Adult Community Mental Health Service. I was looking at the improvements, and the service set 37 actions back in 21. We've completed 26. Can you tell me what stage the remaining 11 are at, please, or give an indication of where we are with that?
Okay, thank you very much. Jill, are you taking that? Yeah, Jill's taking that.
Thanks, Chris. I think there is good progress being made, and we are due to bring back a detailed update in terms of that specific priority. So off the top of my head, unless anybody else knows the actual numbers, it's something that I could get back to you out with today's meeting, but we will be bringing a more detailed report back to the IGB specifically on that improvement plan, and in June the wider mental health and learning disability transformation programme updates also due to come back at that time as well, but we can give you that information out with today.
Okay, no, that's great, thank you.
Thank you. I've got Chris in front of me.
Alison, thanks. Just one bit of clarification for me. Regarding the learning and physical disability service. It says difficulties in admitting individuals with learning disabilities to hospitals when they need treatment. Is that generally, globally to all hospitals, or is it specifically to learning disability services?
My understanding is that refers to learning disability inpatient services related to the beds being available being limited across the whole system, and that the work is required to enable flow within that environment to ensure that people can get in and out of into hospital when they need and back out again into the community, and it's the whole system flow that is being looked at the moment, but I'm happy to look into that more for you.
Okay, will you get back to Chris separately, and I'm sure if we need a paper on it you'll let us know. Yes, okay, thank you. Martin, sorry, it's taken me a while, Martin, because I don't have my glasses on.
It's actually on, thanks for the report on the integrated drug and alcohol service. The long-acting, how view injection, what kind of injections are that?
So there is a variety of treatments available to support people with substance use. There are longer-acting buprenorphine injections, and there are advantages and disadvantages of the various options, some of which are more expensive. However, we do have an approach in Angus that is tailored to providing the best option for that individual, and not limited to what is the cheapest first or anything like that. So it is about providing the best option. Sometimes the most expensive option is not the best option first line, and there is a bit of work to be done around reviewing patients and making sure that they remain on the right option, and that we support where appropriate beyond maintenance reductions. So we do take a holistic view into assessing people for the right intervention there, but some of it is newer and a bit more expensive than historical offerings.
Thank you very much, Alison. And we might be able to pick up Chris's point on the learning disabilities paper when Sandra's on with that. Yeah. Martin, do you want to come back in?
Yeah, I was actually going to ask, how long has this drug been in effect, and what are the outcomes of it, and who's it target at?
So, off the top of my head, it's within the last 10 years that we've been implementing it. The advantages are that it causes less sedation, so people have more ability to engage with their working lives. If you're giving things weekly, it means that there's less stigma because people aren't having to attend. So there are advantages, but some people don't like the way it makes them feel. It can reduce the amount of sedation, and some people don't opt that that's just not the right thing for them at any particular time. So there's pros and cons, and it is a very individual decision as to which one somebody might choose to be placed on.
So that really fits into the realistic medicine concept, doesn't it, around what works best for people, and one size does not fit all. Okay, thank you very much. Alison, I always find this report really helpful. It's great to know the amount of work that is going on across lots of different areas. So thank you for bringing that. It's really valuable, and if you can reflect that back to the group, I'd be delighted to do that. Sorry?
Abby's on. She does all the work.
Oh, Abby, well done. you do all the work. You do all the work, I've been told. So thank you very much indeed. So if you look at the recommendations, are we happy to accept those 3 recommendations as described in the paper? Yeah. Thank you very much indeed. And so moving on now, I've lost track of the numbers. Number 12, which is the Inpatient Learning Disability Transition Update. And welcome to Sandra MacLeod, who's going to present that paper. Thank you.
Thank you, Chair. I think the paper outlines an update from the Learning Disability Transition Task and Finish Group. It outlines the progress against each of the recommendations that have been made and gives a current updated position. This report's been shared through the IGBs for each 3 IGBs, as well as through the governance in NHS Tayside. It's quite self-explanatory. I'm working on the assumption colleagues have managed to read the report and happy to take any questions.
So thank you. So just before I open it up, and I'm going to ask Eunice to come in with a bit more of an Angus perspective. But at the NHS Tayside board meeting last week, I did raise the cost framework is still quite vague, and I know that's being picked up, and also the staffing issues that we have in that whole system. And I was given assurance that these are being developed and there will be more information forthcoming that's more tangible over the summer. So it might be that you want to pick that up on any questions, Sandra, but I'll let Eunice come in first. Thank you, Eunice.
Thank you, Chair, and thank you, Sandra. I just was keen to highlight from an Angus perspective, and the one thing I wanted to point out in 5.2 is in relation to Councillor Speed's question, just noting that we are having challenges around placements for our learning disability cohort, and we are working hard to try and address that in line with the Coming Home agenda. You'll also see we've also got a recommendation on section 3 that we're keen to bring a report to an IGB in June, just really to explore further the impact and requirements that we will need to explore further on the delivery of commissioning social care for this cohort of people. So hopefully that can be approved this afternoon. And just finally to say that the Angus Health and Social Care Partnership, Morgan Lowe, specifically at the back there, has been working very intensively with NHS Tayside supporting the Equalities Impact Assessment, and we will bring more information around that from an Angus perspective as well when we bring our report in June. So thank you.
Thanks, Eunice. And we've got a question from Chris.
Yeah, thanks, Kavira. Just thinking about the impact on the workforce. It's mentioned on page 6 there, the drop-in sessions are held in February. Did we seek feedback from the staff at that session, other sessions, and will that information come to committee?
Sandra, please.
Sorry, I was just referring to the page there. So we had drop-in sessions with regards to the changes to the environment, but there's also been a paper that has been brought through our Chief Exec's team and was then held in reserve business through staff governance for NHS Tayside. That plan outlined an agreement to move to organisational change for the Learning Disability Service in line with policy, and also brought forward a recommendation that we would prepare a training, transition and recruitment plan, which was one of the strands that will look to support the workforce and how we're moving that forward. That paper is expected to be taken back in June, along with some firm dates for when the moves will take place through there, so will likely be in the further updates that come through in the next session to the IGBs.
Okay, thank you very much.
Thank you, Sandra. Lois.
Yeah, thank you. It's in relation to 7.3. And in particular, that kind of last chunk of the paragraph where it talks about from the work being progressed to date, it's likely that there will be significant additional financial costs to the partnership. And then it goes on, and then the very last sentence is just you're midway through, or someone's midway through. It says the model will be. Are you able to complete that so we have an understanding?
Yes, I am. If you go right, the model will be affordable and provide best value.
Okay. And I really don't like to ask for another follow-up again, because I know I've done it a few times already, Chair, but if I could just, now that I know what the last sentence is, would I be able to just ask for a bit more explanation? And if you could kind of, within that, what, how much kind of weight will be given to the human cost and ensuring that we get it right for every individual impacted who we're trying to settle back in and bring home into the community?
So we are taking a person-centred approach. So everybody that is in this cohort, we're looking at their individual assessed needs. We're looking at, opportunities to see what we can do across not just this partnership, but with Perth and Dundee, around for people that have got really high levels of very, very complex needs, presenting with extreme challenges in their behaviours. We're looking to see if we can do things together. And making sure that we do the right thing for people. So we have looked at some resources and we've felt, because it's not in line with the Coming Home agenda, it's too far away and things like that. We've ruled these out because we have to keep people at the centre, also be mindful of the views of the patients and their families as well. So that's very much part of what we're doing as we consider these individuals and what we do going forward. And as I say, there'll be more information coming the next time that we're at the IGB. Thank you. Thanks.
That's why I raised the cost framework at the board. Okay, thanks. Okay, any more questions or any other points that you wanted to pick up, Sandra? Happy with that? Great. So we've been asked, we've got 3 recommendations there as described. Are we happy to approve all of those recommendations and look forward to the next update in June? Sandra, thank you very much. If you need to go now, please do. And thanks for coming today. Okay. And we are now moving on to the primary care update, item number 13. And that's Lisa. Super. Thanks, Lisa. Yes, that would be great. Just so you don't have to sit with your back to some people. Thanks. Just give Lisa a second or two to get to the front. Thank you.
Okay, so this is one of our regular updates that we provide for primary care, and it's a follow-up to our October report and details really what's been happening in the world of primary care improvement during 24-25, and an update with our Angus, gosh, I can't get my words out, Angus primary care practice premises strategy as well. I think the links between workforce and premises and their impacts on GP sustainability are well known and well documented and have been reported here previously. And we're recognised by the government in 2018 as well with 2 very important policy drivers around supporting general practice, both in terms of the new primary care improvement plan and the new national code of GP practice premises. So this report details everything that we have been working on during the last year in terms of primary care improvement, and key things to draw out from that are the work around our community care and treatment centres. As many of you know, we had a redesign of the model, and work has been continuing with lots of work on that area over the last year, bringing it back into our practices within Reach clinics and trying to make it as accessible as possible. There are still challenges because this is a growing area of demand, along with general practice. We see the demand also in services linked for our multidisciplinary teams working with practices, and so we continue to work on that, but at the moment capacity demand does outstrip capacity. There are opportunities with this though as well, and over the last year we have had some successes in terms of working with secondary care colleagues to look at pathways for diabetes care that have rolled out, and there's some pathways, new pathways with mental health, and opportunities for the forthcoming year remain around working with colleagues in vaccination services as well. The other area that I would like to highlight is our urgent care nurses. I think I have reported on this previously. This is an area that has continued to grow. For us in Angus, we've been very successful with our recruitment, and this team really do support the work of our general practitioners, taking on many areas of work that would have previously been delivered by GPs, and that's an area that we've been very successful with, and it really helps sustainability. Moving on to our premises strategy, there is an ask in the paper around and a proposal around looking at some of our property reserves and putting an earmark around those to help us be able to kind of continue our work with premises. There has been work ongoing over the last year. We have 3 priority areas in terms of premises that are captured within the strategy as our main priorities around Kirriemuir, Forfar and Montrose. But all of our practices have differing needs and issues, and ownership and the leasing of practices, it has a real impact on practices' ability to recruit. And you know, the government's intention was to see a generational shift towards board owning and leasing practices. That remains. There's been no update on that policy driver. There are challenges around that, not least the financial position. And as we've seen this year, there's a new system for capital allocation been rolled out to health boards, which means that our prioritisation is considered along with all other priorities across NHS Tayside, hence why we would like to ask around the earmarking of our reserves in order to use some of our local reserves in a most productive way to help us take forward some of these challenges areas to protect our practices and help continue to deliver care to our local communities.
Thank you, Lisa. I just wondered, further to the recommendation around the earmarks, what sort of timeline are we considering there?
So there are various stages for all of the projects. I think it would be conceivable to come back in a few months' time, because what we're asking for is to work up some of the detail around the earmark in order to then come back with a proposal as to how we would take that work forward. So I think October or December time would be reasonable.
That's helpful, thank you. I'm sure Jill will pick that up. Okay, I'm going to throw open Sam's first, and then I'm going to suggest that maybe Alison and Andrew might have something they would want to contribute next. Sam.
Yeah, thanks, Lisa. Thanks for the paper. Very extensive. In 5.7.6, you talk about the technical staff work constraints. Is that still an issue? How long do you see that continuing for?
So that relates to NHS Tayside, and it's about capacity, Sam. So, you know, obviously our work is one of many priorities for the property team within NHS Tayside. And as I said, there is a new prioritisation towards capital planning. So whilst there isn't anything specific for me to update around that, that is something that obviously would be part of the work that we would look you know, if we look at these projects, if we have that earmarking and we take forward that work, we would maybe look at, well, are there opportunities to, you know, buy in technical help, look elsewhere, fund resource, additional capacity. So that's one of the things that we would use that for.
I think they're coming out of retirement, Sam. So, Alison or Andrew? Alison first.
Thank you, Chair. And I welcome this report. There's an awful lot of work goes on, and this is just a summary, really, of the wide range of work. I think it's important that we see primary care beyond general practice and linked in with the wider healthcare system around our care closer to home, prevention of and proactive care work and our mental health work. They are all key and they're all linked in. What I would like to highlight is paragraph 5.64, which is around the variation in terms of our various geographical areas in Angus, and that we do need to tailor our services to meet the needs of the individual practices at the same time as being equitable in how we approach, and so that does sometimes need a wee bit of tweaking as we go along, and I'm looking forward to seeing how that develops. I think that is key for me, that we ensure that every community and every registered with every practice has access to the high quality care. But overall, welcome this report and look forward to seeing how things develop.
Thank you. Andrew.
Yeah, thank you, Chair, and thank you for this report. I echo everything that Alison says, which is unsurprising. But I also specifically think that as we develop this report in future, I think actually it would be useful to see some mention of how this sits in context, because this is very much GMS contract, very much GP based, and actually seeing it in the context of the wider dentistry, optometry, pharmacy, etc. Sort of picture of primary care, I think would be helpful to see that overall structure. I agree also with sort of equitable rather than necessarily equal spread of services based on population need across the various parts of Angus, because the needs of residents in one part of Angus can be entirely different from the overall needs in another. I think I highlight my disappointment in terms of the this is more about central and government sort of allocation. The very fact that we're in a situation where we've got a budget for premises that has no primary care projects in it for the next year. I mean, I'm not sure how that fits with moving care close to home, and government policies just recently reiterated of shifting that. If we don't have the places and the premises to be able to support high quality care, both social care and health care in the community, then how can you have the infrastructure that's available to shift that care out of hospitals and out of central and make it easier for our residents to access that care? So I guess it's noting my disappointment on that. So I think that is very short-sighted, and there is significant discord between that and other Scottish government policies. Just one, and apologies for being my usual picky self, but can I just in 5.1, and especially 5.1.1, it's not the Primary Care Improvement Fund that continues to shape the evolution of primary care, it's a Primary Care Improvement Plan. So the fund itself supports that, but the plan is what directs it. And in 7.1.2, the contractual approval of spend is from the local medical committee rather than the GP subcommittee, which is an advisory board to NHS and to the HSCP. So thanks.
Thank you very much. Any more questions? Martin? Sorry, I was just scrolling back to a different point. Thank you.
Yeah, it's on 5.1.2, and it's the last sentence. It says that provided the opportunities for efficiencies, have these efficiencies been realised? Have the opportunities been realised? It didn't tell me very much, I'm afraid.
I got a sense that was more about multidisciplinary teams. Oh, hang on a sec. We've got Alison and Andrew waving frantically. So we go for Alison first.
So I would just like to give some examples. For example, within the Primary Care Improvement Fund plan, we have been able to recruit peer support workers for mental health, which has enabled a greater reach in terms of the amount of support that we can offer in the community, and it has released our mental health workforce elsewhere in the system, and that has been a real strategic benefit to us. Terry Irvin's idea some years ago, it really has worked. Another would be within CTAC, by employing our healthcare assistants and supporting them with a make every contact count approach, where they're able to give health promotion advice, and that's everybody's responsibility to give health promotion advice. But that has released the workforce within primary care practice nursing to do more of that complex care planning and assessment that the role requires. And that I could go on, but that's a couple of examples where the Primary Care Improvement Fund maybe doesn't within service release resource from the workforce, but certainly with the wider system, and it does help GP sustainability.
Thank you very much. Andrew.
Again, Alison has said the vast majority. I mean, there are multiple examples. This is constantly evolving implementation of the contractual resources, constantly evolving change in teams. I think it would be far too detailed to be documenting it within this type of update report. Down to something as simple as just a percentage of healthcare assistant versus nursing appointments within CTACs, length of appointment times, the realisation that perhaps CTAC modelling being in central hubs rather than close to practices in some areas of Angus was perhaps a model that wasn't working, and therefore we've improved on that. So there are multiple things. I mean, just on peer support, I mean, that's a key difference between us and other HSCPs. It is a significantly more efficient model. So it is then freeing up the finite resources of the Primary Care Improvement Fund to deliver other areas, such as the urgent care nursing, but at no detriment to the mental health provision, because actually I think we are having, well, I know we are having significantly more contacts with patients to provide that support versus other areas where it's a more specialist service, and therefore far fewer whole-time equivalents employed to do that. So again, it's looking at the type of skills we're using and complementing existing systems rather than duplicating or overlapping.
Andrew, thank you. I think Lisa wants to come in there, and then I've got Chris on screen. Thanks.
Yes, thank you, Chair. Just apologies, I had to familiarise myself with what that paragraph was. Yes, so thank you. There are many examples, as Andrew's referred to there, and I think, you know, the ones that are the most notable for myself, I think we've done a tremendous amount of work in CTAC and also with the pharmacotherapy service as well, because the original plans by necessity around how that was envisaged to look and how it actually looks because of the challenges with workforce mean that there has been some real innovation that's taken place in those services. But I think generally, you know, it has been a learning journey. It is very much, it's a great team of people involved in this, both locally and regionally, and we work very closely together, and we have taken it as a quality improvement focused approach, and really there is a lot of effort that goes in to make sure that we are making these services as responsive as possible. And when we know something's not worked well, we have drawn back from it and re-looked at it and revised things, and CTAC's a great example of that as well. So thank you for bringing that up, Andrew.
Thanks, Lisa. Chris.
Yeah, thanks, Convener. It's not so much questions, more a request than maybe a stroke comment. Paragraph 6.2.5 on page 69 in relation to EDSL. It's quite a worrying time for the people of EDSL. If that looks like the practice is going to be removed, you know, can we have as much information about that as possible, please? You know, so that we can disseminate it.
Okay. So, okay.
So the confusion, sorry about that, is because you're reading the old papers without the minutes combined. So it's page 78, and I think Alison wanted to come in on that, but we've caught up with you. Thanks, Chris.
Thanks, Camilla.
Yeah, I wouldn't want to comment too much in detail around the planning that might be going on for EDSL, but we do have a Brechin and EDSL development group. We are looking at that area with a supportive approach as to how we build resilience across Brechin and Edzell with recognising the codependencies. Some of that work is reflected in terms of the response to the storm recovery and how we build resilience in the area and how we look at working effectively with multidisciplinary teams in the area. One of the things with Edzell being a single-handed practice, you've got 1 point of failure if you're relying on a single-handed GP. So we do have mechanisms in place to provide cross-cover, which will make that role far more attractive for the future, looking at retaining where we can health services in that area. And there are some positive shoots in terms of the doctors working in Edzell, where we have got opportunities for the future to recruit and retain medical staff, but also the wider multidisciplinary team within that area and really develop it for the future positively. That work is very much in progress and is very much supported across the resilience in the area, recognising a place-based approach.
Thank you. Lisa wanted to come in on that as well, Chris.
Okay, thank you. So just to follow up with what Alison said there, really, whilst there is no specific timeline around Edzell, and I wouldn't wish to cause any undue alarm, I think it's dealing with the realities that, you know, we do have a predominantly older GP workforce in Angus, and that, you know, when there are single-handed practices, there can be additional vulnerabilities. However, what I would like to emphasise during this is that, you know, we're not sat on our laurels just waiting for this to happen. This is a proactive piece of work, which is why we're wanting to get ahead with this and really look at ownership overall for GP practices and you know, continue to be proactive around this, just as Alison's described. Thank you.
Thank you, Lisa.
Okay, Lois.
Yep, thank you. As you know, I've been in touch recently with regards to kind of communications, the feedback from the public in terms of service users and some of the challenges that they've been having communicating with their GP practice, telephone lines, lengthy call wait times, as you know. And you know, I think it's a mixed response, because in amongst a lot of that feedback, there was positive stories as well, which was really pleasing. And I know, as a member of IGB, that there's a lot of work does go on behind the scenes in terms of, you know, addressing those issues and looking at improvements. But I just wondered what plans there were to kind of maybe communicate more with the public around GP practices and the challenges, as well as the aims and ambitions moving forward. Do you think more could perhaps be done to involve them in that conversation? Because, you know, a GP, as we all know, is usually the first point of contact when someone isn't feeling too well or is worrying about something. So do you think maybe need to involve the public of Angus more in that kind of conversation and direction of travel?
Okay, so thank you. I think that in terms of communication, certainly some of the projects that I've been involved with recently such as the MIU, which will be bringing a report later on in the summer, you know, the importance of communicating with our local communities and getting that feedback is essential. And I think that, you know, there's always room for improvement, and I think that that's an opportunity for us to do so more with issues around general practice, which I know even from just, you know, the output that we get bringing these reports it's a great, you know, it's of great interest to everybody, because general practice is at the heart of everybody's community. You know, everybody generally will see a GP, and I think in terms of opportunities for further communication, I'm conscious that there will be a GP strategy, a Tayside GP strategy being worked up. So
I'm actually curious and thoughtful. We could maybe do a podcast on GP access in Angus, something quite simple like that, and we can work with Alison, Andrew, Scott, etc. Around some of the GP access principles from a national perspective, what that means for Angus and what we are doing to support and improve access to GP practices in its widest sense across Angus. And that we will give further thought in terms of how else we can continue that conversation with the public. Councillor Speed.
Thank you. I've also picked up a few access issues recently, And also, I did wonder in the paper some of the challenges around pharmacist recruitment, how that might impact on Pharmacy First as an approach. So I guess just taking that in the round, and I think Scott would be quite helpful in that. So Andrew was wanting to come in there.
Yeah, thank you, and I certainly agree in terms of focusing on a sort of communications plan and engagement plan with the public. I think we don't do enough of that. But just to update, perhaps more with my sort of Tayside rather than Angus hat, we're just about to relaunch a whole suite of materials related to the GP contract and the increasingly wide and diverse multidisciplinary team and how they are used, the roles they have and how you access them. So that suite of materials is coming to a meeting next week to be signed off, and then the comms team at NHS Tayside will be distributing that in a form that can be used on websites, will feed into social media, etc. So part of that communication plan will include some work on access and how you access and the best person for your care, because whilst GP's been used a lot, actually it's not GP, it's the GP team. It's a much wider team and getting wider by the year.
Thank you. Okay, I think that's that. Good. We can go back to the recommendations now.
Sorry,
Oh,
that was my question, but I also just wanted clarity before we move or agree the recommendations. Within the recommendations on 3.4, we've been asked to approve that from existing reserves, the IGB work towards creating earmarks to support the progression of the Kirriemuir and Academy proposals, but noting that any finalised plan to deploy reserves in this way would be subject to further IGB approval. And yet in the body of the report, under number 7, I think it is, GP practice Kirriemuir, on the premises, sorry, I think it's number 7, it perhaps reads as if we are agreeing to that spend, but just clarity on that. How much of the reserves would you be utilising before you come back with a plan?
Sandy will take that.
Yeah, thanks, Councillor Speed. I think the wording that we should reflect here in terms of the decision is the wording in the recommendation, which is not specific about a figure, but just sets out that we're going to work that up. So we've got a few things that we're juggling and priorities and just trying to get the right balance of things. And a few minutes ago, we talked about, I think, so one of you asked how long might that be. You did, Councillor Bell asked how long that might be. And there was, I think, Lisa, you said maybe October. So we've still got a few things that we're just working through. So yes, there's not this, because an exposure, a cost quoted here, and we know roughly what it might be. But I think we're going to try and bring all that together when we come back with that and try and deliver the recommendations. So we'll be more specific about that when we come. So you can see a rough scale, but we'll try and be more specific. Is that okay?
Yeah, and you're not looking to utilise that reserve at this time? That would be at a later time?
No, I think both Lisa and Sandy were pretty clear that, and it says in there, it's subject to further IGB approval, and Lisa did say October, December to fit in with our IGB arrangements. So that will come back. It's just to get that approval to move the thinking and the planning forward. And I think the cases were made really well in the paper, and I think we've been aware for some time some of the challenges. Just for the record, I'm not a patient at Kirriemuir, but I know that will be really helpful, and it will, I think, provide some significant reassurance to the community, because it does serve quite a wide rural area, and I'm really pleased to see that we're moving forward with a commitment to look after that practice and their premises, if you like. Also pleased about Academy, just for the record. But I'm very reassured that it will come. Nothing will happen without further IGB site. Is that okay?
Yeah, absolutely. I just want to know what I'm agreeing to, and just what, especially when it comes to financial spend. Thank you.
So going back to the recommendations, the only other query I have is the timeline on requesting an update on the direction. Will we have that for the June meeting? That's fine. So on that basis, are we comfortable approving those recommendations, please? Super. Thank you. I'm going to give you a heads up. I would quite like to get through to the Director of Public Health report and have a break before that. But is anyone wanting a break now? Does anyone want a break now? Yes, if that's all right. Can we have a 10-minute comfort break, please, everyone? And we'll see you at 14:48, say. Thank you very much.
15:40. John, can we stop the live stream, please?
Could people take their seats, please? Excuse me. Okay. Thank you, everyone. It's a bit of a rush there. Okay, thanks very much. So welcome back, and we're on agenda item 14 now, which is the Joint Angus Advocacy Strategic Framework Progress Update, and I'm delighted that Eunice is sitting here with us to take us through that. Thanks.
Thank you, Chair, and good afternoon, everyone. It's nice to be here. So this Joint Angus Advocacy Strategic Framework Update, just to clarify, that's between Angus Council, Children, Families and Justice Services and Angus Health and Social Care Partnership. So this is an update report, and you'll see in the action plan there's been extensive work done since we last brought information to the IGB for consideration. You'll note in the report that the role of advocacy is an essential component of meeting the health and social care requirements of people in our community, and it's an opportunity to provide a critical voice for people meeting their health and wellbeing ambitions. So it's a really important framework that we've got responsibility for. This year, we're asking that that we bring annual reports. I think when we first brought the report, the IGB asked for 6 monthly reports. We are slightly behind with that, so my apologies for that, but we have got it here now. We would like to bring reports on an annual basis, if that's agreed, because we're able to offer a reasonable level of assurance today. When you see the action plan, the amount of progress that has been made is quite significant. We're also asking for an extension in the framework, because we're embedding the work that we're doing. We're making progress, but we're embedding it and not identifying any significant changes that would suggest that we need to redo the framework between 26 and 27. So we're asking that we have that extended. And I'd also like to say thanks to Sally Wilson for her work, important work in this area. I'm happy to take any questions, as is Sally, who's here today as well. Thank you.
Thank you very much, Eunice and Sally. And just mindful in terms of the recommendations that there will be new local government elections in the May that year, so maybe the timing might be adaptable, just to tie in with any new representation that you have. Any questions for the framework? Lewis.
Thank you. We know that there is increasing demand and need within our communities, and I just wondered if the piece of work around advocacy and independent advocacy, where you were looking to identify gaps, where maybe there wasn't adequate funding to enable certain groups within the community to be supported, did that piece of work conclude and flag up anything that maybe we'd need to consider additional funding?
I'm going to ask Sally to answer that, but we have concluded that piece of work, but I'll let Sally explain further. Thank you.
Thank you. Thanks, Councillor Speed. The initial piece of work has concluded, but I wasn't happy with it, to be honest, and I feel that we need to do further work. So it is still work in progress to identify areas of unmet need in relation to independent advocacy.
Thank you very much. Any more questions on that? Okay. Eunice and Sally, both of you, I know how much work has gone into this. So you've had a number of iterations on the back of feedback from the IGB. So thank you for bearing with it. Can we go to the recommendations then? And I think recommendation 2 is an acceptable request. I'm very happy to support an annual update in future, but I would encourage you to accept all the recommendations there as stated, with a slight caveat around the timing that you can consider. Okay, everyone okay with that? Thank you very much indeed. Okay, and then we are over to John. Hi, John. For item 15, which is the Social Care Planned Procurement and Commissioning Service Development Plan. John.
Thank you, Chair. It just rolls off the tongue, that title, doesn't it? OK, so I'm pleased to bring this paper to IGB today. You'll note in the paper, and it shouldn't really be of any surprise to anyone, the significant proportion of support services in the community that is commissioned externally within Angus from providers, which obviously follows robust social work assessment. And you also note our ongoing work around reduced unmet need, which is good. And there's been some good progress there over the past few months. However, as has been discussed a lot today already, we do know that we face significant long-term funding challenges. So this report really follows a previous report to IGB where we did agree to review our current market facilitation statement to ensure that it is aligned to current and future demands, and that also takes into account the current and future financial demands. So our current market facilitation statement is aligned to the IGB Strategic Commissioning Plan 23 to 26. That plan will be updated next year. So the market facilitation statement that you see today is an interim market facilitation statement, and it's been drafted in Appendix 1 in the papers. And the intention would be to have a full market facilitation plan to be developed for 26 to 29 to align to the next IGB Strategic Commissioning Plan. If approved today, a commissioning implementation plan, which is also in your pack as Appendix 2, has been drafted to support the rollout of our interim market facilitation statement. And there's a number of areas here. What we hope and what we intend is that we can do things creatively, that we can do things differently going forward. One of our intentions would be to host a provider engagement event to launch this interim market facilitation statement, and that would be alongside colleagues from Angus Council Procurement, alongside VAA as our third sector interface, and also alongside our colleagues in Scottish Care. It's great that Gemma's here today, and I know we've had some conversations as well, Gemma, and have been part of those discussions. As I say, we want to work differently within the sector, provide more opportunities to engage face-to-face with providers, gives officers the opportunity to highlight the current pressures alongside what the current and future needs are, alongside contract monitoring expectations ahead of our next iteration of our strategic commissioning plan. We've also had savings identified within and has been highlighted within this report around our monitoring, and the outcomes that we would expect would be efficiency savings of around 10% alongside this, which would be our lower level needs in terms of our grants and contracts. But we also want to, as I say, do things differently, be creative and encourage growth and expansion where possible as well. And you'll note the proposal section that a number of options are put forward there for consideration today. So there are 7 recommendations, including 2 directions for Angus Council, and I'm obviously happy to answer any questions that you may have. Also joined by Morgan Lowe, our Service Leader in Improvement and Development, who I'm sure can contribute to any answers as required.
Thank you very much, John. I just wondered if either Morgan or Gemma wanted to contribute anything at this stage. No? Desperate shaking of head there. No? Okay, thank you. But thanks for the name checks for people. It's appreciated. Any questions for John on any of the points here? Lois?
Yeah, thank you. Just with regards to the combined impact assessment, and under some of the protected characteristics and human rights, it's noted that there would be the potential for positive impact of service users within those kind of groups. I just wondered if you could, very briefly, I don't want to take too much of your time up, but just very briefly, what would those positive impacts look like?
Thanks, Councillor Speed. I'm very happy to ask Morgan to come in on this, who is our expert around all things on this. So, Morgan, if you want to take this one.
So this is in relation to addressing unmet needs. So if we can encourage more providers to come into Angus to support individuals that we've identified here, that's got to be a positive for us. We're looking for new providers to come in, or our existing providers to expand. So absolutely, that should be a positive impact, and hopefully reducing our unmet need overall. So that's what we're addressing there.
Thanks. Thanks. Microphone, Lois, please. Thanks. Anyone else? Yes, David.
Thank you. The table on page, in my version, it's 109, page 109. I don't know if I've got the old version or the new version. 2 questions on in the table. One is regarding care home accommodation. There is no reference to respite care provision. think the numbering changed if you got the minutes and I didn't get the minutes.
So bear with us until we find the page on the combined pack.
I think there are another, did you say 10 pages?
There's another 10 pages or so. So clearly it's my fault. I'm the outlier. I've got the combined pack. You guys don't. Sorry.
109.
109.
Thanks for the question, David. Just as we find it there, obviously you've raised...
The table, current priorities and potential future models.
Thank you, thank you. Okay, so I think what we can look to do going forward, because obviously we do have respite beds within our care homes. You're absolutely right, David, and we have those as planned respite and as a response to emergency as well. So we don't have a huge take-up of our respite beds, and there's often been some gaps in provision there where we've not required to use those beds at points in time. So I think going forward, and this is where having that face-to-face session with providers is going to be really, really important, because we can then discuss what are the needs in Angus, what do we think the needs will be going forward, how do we ensure that we've got the correct provision set up. So do we have the right number of respite beds? How do we ascertain that? We can take what we know in terms of our current usage. We can try as much as we can to look ahead to what we believe future usage may be, and try and be as informed around that. And I'm absolutely happy to have further conversations with you about what those needs could look like going forward, and certainly take advice and guidance from those who have caring responsibilities. We've also got our carers plan, and respite is obviously a part of that. So we need to make sure that the two marry up. So more than happy to make sure that we reference that, and when we have that face-to-face discussion, that could be a specific area that we focus on as part of that day, particularly with our care homes. So hopefully that helps. But I'm happy to have a further conversation with you if that's helpful, David.
Thank you for that. That's reassuring. I'm conscious that there's been a reduction in the number of residential respite beds available. I'm also conscious that the costs of respite have gone up, and both those things can have an impact on whether people are asking for or using the service. So I think a more extended conversation to dig into those issues would be beneficial. The other question I had was in regard to the opportunities framework, which crops up here again. There's a reference to work will support us to deliver our financial objectives as stated in August 24. I had trouble finding that reference, and I would appreciate somebody highlighting that to me, because until reading that, I wasn't aware that we were focusing on a financial objective. It was about a service refocusing rather than, and I can't find the reference, so if somebody could oblige me with that, either immediately or more likely out with the meeting, I would be obliged. Thank you.
Yep, David, happy to find that reference and make sure that we confirm that for you. And I think it is worth saying that this work, there's a financial element to parts of it. I think what's referenced within the report is where we can look for efficiencies will be through some of the non-statutory provision that we have, which tends to be our lower level needs. For those other needs that are sourced and paid for, that are statutory needs, that's not part of this. This is really looking at how we can expand, how we can make the most of what we have, and how we can improve services. But we'll find that reference and we can pick that up outside the meeting. Thank you.
Thank you. That's helpful. Martin. And sorry, I know I'm aware Chris is waiting as well, but Martin first.
Thanks for the report. Just for clarification for myself, care homes are determined as care, no nursing in care homes. Or is there any specialised nursing like for dementia? And because just that clarification, care homes or is it care homes with nursing?
Thank you, Martin, for the question. So, probably get the term relatively generic. It includes care homes, it includes nursing homes, also includes residential facilities, not just for older people, but for adults as well, who require that 24/7 support. So it encapsulates those three elements of care home provision.
second question, if I may. Has there ever been a consideration, if there are small care homes, that they form into a care home cooperative?
Thanks, Martin. Possibly going to look over to Gemma and Scottish Carer on this. I'm aware of care home cooperatives that exist in other areas. I think what we have in Angus is the challenge that we have in Angus, and that's part of the driver towards this work, is that we have a number of small care homes. What we're seeing nationally when we see care home development is generally larger care homes are being built. They're much more financially sustainable. Obviously, they can have more individuals that are cared for within the one site as well. Gemma, I don't know if you want to come in from a Scottish Care perspective. I know that providers meet regularly. Providers do support one another. We have good examples, even going back to right at the start of today's IGB, when we had the evacuation from South Grange. Care homes are able and willing to support one another through business continuity arrangements where they'll care for other residents if that is required. So there is a reciprocal arrangement, but in terms of an actual collaborative, I'm not sure if that's something that Scottish Care might want to come in on.
Yes, thank you. So there's nothing established at the moment in terms of an actual collaborative within care homes, but as John said, they do work really closely together in Angus. We meet regularly, and out with that, the care homes liaise with each other regularly out with those established meetings to make sure that they have ongoing communication. As John said, they're fantastic in terms of supporting each other in times of need, and they will definitely do all that they can, but that's something I can certainly take back to our next providers forum to discuss further with them.
Thank you, Gemma. That's helpful. Okay, good. Chris.
Yeah, thanks, Convener. Actually, part of my question may have just been answered, I think, but again, looking at page 109, 1010, for the potential future model and the invitation to current care providers to expand the number of care home beds, how confident are you that this is achievable given the pressures that are on the industry just now?
Thank you, Councillor Beattie. I think this is why we need to have the initial conversations and opportunities to bring providers together. This is something new and innovative. We're really committed to trying to be creative in terms of how we can sustain providers. We know that, and it's referenced within the paper, we have lost one care home in Angus in this past 12 months, and that does have a significant impact on the availability of resource. So I don't think there's an option for us to do nothing around this. I think we need to do something. Keen to gauge interest from providers, keen to gauge, as we've discussed already, the ability potentially for providers to work collaboratively together and consider how we can not only sustain but expand and potentially attract new providers into the area. We know that we're seeing some care homes being built in neighbouring authorities. So how can we encourage individual providers to come into Angus? I think it's through opportunities like the one that we're considering, trying to be much more frontward facing and engaging with the providers. And from conversations with Gemma and Scottish Care, we believe that that will be really well received by providers and will hopefully be the start of our helpful conversations. But I think it's probably too early to say at this point, but the hope is that it will be seen as a potential welcome resource and opportunity for providers.
Okay, thank you very much. Sandy would like to come in.
I'll just clarify from the earlier question where the August 2024 reference came from. It was from a finance report in August 2024, report 5224, Appendix 5, and it covered a whole set of areas, not just the opportunities, which is maybe why, Dave, you're not finding it.
If it helps, Martin, quite often when these previous reports are referenced, I save all my paperwork on my desktop, which probably IT are not happy about, but that's what I do. But they'll be available online as well, so you could go and research them if there isn't a link available. But they are in the public domain. Okay, thanks. Okay, so on that basis, can we go to the recommendations, please? I won't give you the page number because I'm out of kilter, but there's 7 there, and the last one contains 2 directions to Angus Council. Are we all happy with those? Sorry, Lois,
Sorry,
So
just again,
because we're close to
we're
signing
almost
this.
there. Yeah. Sorry, just clarity again on the recommendations. Again, within the recommendations, it doesn't kind of have an ask in terms of any financial ask or saving, but within the body of the report, again, under the proposal section, it mentions a saving that's to be identified and made within. Back to the, so it just clarity on that again as to what we're being asked. Apologies, maybe just my brain's not working today, but.
Sandy, do you want to come in?
Yeah.
Mike, please, Lois.
Helpfully, I can also point you to report 5224, because the two are linked, Councillor Speed. So the question before, I think it was Dave, was asking about the day opportunities, and there was a figure associated with that. That was in a financial report from August 2024, Appendix 5 of that. And the saving that you see, the saving figure that you're seeing in the financial implication, which I think is the one you just referenced, that was from that same report. So that's already been agreed last year. It was one of a number of things that we were putting together during 2024 to help us over multiple years. So that's already been agreed, but it's separate to things that are in today's recommendations. Hopefully that makes sense.
Okay, thank you. Right, so can we approve those recommendations as stated, please? Thank you very much, that's great. And moving on to item 16 now, which is the Director of Public Health Annual Report. Now, I don't think there's anyone from Public Health with us today. I think helpfully, Alison, you're going to support it as far as you can. If there are any specifics that we're unable to answer, then we'll take them away and get a response to that. I'm going to suggest that we talk about the annual report first before we look at the screening tool. We'll do that separately. Is that okay? Great. Right. Are you taking it to start? Okay, Jill.
I'm not going to take it in any level of detail. I think just to give apologies, there was meant to be somebody from Public Health coming along. Obviously, we have lost Emma as Director of Public Health and are awaiting a new appointment within that role. However, we have had a development session prior to Emma departing, and she did give a presentation on the actual annual report itself and what it meant for Angus. So members will have had that opportunity to review the report prior to today and as part of the session with Emma. So just wanted to highlight that, Chair. Thank you.
Thank you. And if you remember, last year's annual report was what triggered us including the public health impact section of all our papers. So that's been a tangible action from that, and it helps us to focus our minds on population health, and that's why we've got the screening tool here today. So any questions on the annual report? Some of us will have seen this in other areas already. So Lois.
Yeah, thank you. I just wondered if you could provide a brief picture in terms of breast screening in Angus and how accessible that is that for women across Angus. Do note that there are perhaps some improvements to be made on. I'm going to stop now because you're looking. Maybe you don't have the answers to that, but it would be good to get perhaps feedback.
I can take that question away, Councillor Speed. It's not something that the Health and Social Care Partnership has responsibility for. That does sit within the acute services delivery element of NHS side, but happy to take that away. If you've got any specific queries, then we can maybe pick that up out with the meeting.
Mike?
I guess, yeah, ultimately I'm just keen to be reassured that that is something that women within Angus can access easily, and that there's no areas or unmet needs or gaps in that service. Thank you.
I'm certainly aware that the outreach is quite significant into communities using the mobile vehicles. It still says it's in Montrose at the moment, and they tend to stay for ages in those more dispersed locations. So, yeah, from a recipient's point of view, I find it accessible, and also there's public health messaging around the importance of women taking them up at every opportunity.
So not specifically on breast screening, although I would agree the breast screening van does move around all locations in Angus, and those in the area that are due their screening do get invited. But in a related point, I think it is worth highlighting to the IJB that the healthy life expectancy of women in Angus has decreased, the healthy life expectancy of men has increased, and that has meant quite a significant shift whereby previously men would be expected to live less long and healthy life. That situation is reversed, and now it is women who have poorer outcomes in terms of how long they can expect to live for healthily in Angus. I think that we need to consider asking for more detailed information as to what is driving that and look to address any health inequalities there. I could speculate on what might be contributing to it, but I do think that indicates the importance of us getting this data and being able to analyse it in this way. I think there is work to be considered through the Women's Health Plan or the next iteration around how we look at women's health in particular.
I'm sure the WASPI women can speculate as well around the impact on women's health and extended working lives. Okay, thank you. Martin. Yeah. Could you start again, please, Martin?
Okay. Yeah. Page 160. And you've got some percentages there. And when you look at the bottom, and I do remember asking Emma this previously, when they talk about 22% of Angus, 26% in Dundee City and 18% in Perth, the children living in poverty. And I asked the question, is it relative poverty or is it absolute poverty? And because when you look at the one above and the amount of people in employment, 73%, 76%. Then when you look across in the lower paid employment, does that correlate why you've got all these children in poverty? Because they're actually showing people are in employment. So I'm not sure what type of poverty, is it relative or absolute?
So I know there are a lot of people in work who receive benefits. In-work poverty has increased over the years, but that's maybe a specific that we can pick up. Okay, thank you. Anyone? Andrew.
Thank you, Chair. It's really just a general comment and to note thanks to Emma and the Public Health team or Population Health team for pulling this together. I mean, I think this style of report was first out in last year's report, and I think it's a very helpful and accessible style of report and enables this to be the reference document for us in all of our considerations and feeds into that section that we've put into reports. So it's really just to acknowledge and thank the team for this report and ask for same again next year, please.
So you stole my words there. I was going to round off with exactly that, because Emma will be a sore miss in the organisation, and there is going to be a wee gap. But I think reflecting back, how we like this information being presented is key, I think, and of course you'll have an opportunity to feed that in as well from various fora. So thank you for that. People happy with that? What I would suggest, if you have any specific questions, if you fire them in to the Health and Social Care Partnership, we'll feed them on. Okay, and again, thank you very much for the effort in the content. So can we move on to the screening tool now? I had a wee suggestion to make, and it's entirely up to you whether you take it or not. I thought it would be helpful to have on the screening tool just a statement that impacts will be reflected in our annual performance report, just to tie it in rather than just have it sort of free floating there. Jill was nodding away there. So any questions or any other comments around the screening tool?
Thanks. Julie, I guess just in terms of reflecting back to the statement you made around when the Public Health Annual Report came last year, and how we then started to include public health on our IGB reports. This is, I guess, the next stage for us in terms of that work, so that we can really make an assessment in terms of the impact of the decisions that our IGB are making in relation to the wider population health. So Morgan has a number of different hats on and expertise, has been working closely with public health colleagues to develop the health impact assessment. And it's not to add a lot of work to officers doing the reports, but it's actually to put the level of importance that population health does actually have, and how we can really demonstrate the impact, but monitor and demonstrate the outcomes of that as well. So I just wanted to, we are on a bit of a journey with it, just a section in the report, and this is our next part of that to try and improve that even further.
Thank you very much. Thanks, Morgan. And do you know, is this being shared across the other two health and social care partnerships, do you know? So we're a leader in that, a bit of innovation from Angus Health and Social Care Partnership. So that is a literal outcome from last year's Public Health Annual Report. So I'm really pleased to see that. I think we'd be happy to share it if anyone wanted it, wouldn't we? Yep, fabulous. So if we can go back then, just let me find the actual ask. I think we're just being asked to note it. Right, okay, acknowledge and discuss. Request an update on the actions and progress relating to the prevention and proactive care study, and consider and discuss the health impact screening tool. So are we all happy with that? That's great. Okay, so I think if memory serves, that's us. If I can go back to the actual, my laptop is freezing. When's the actual date? Let's kind of get to it. I'm completely frozen. So the date of the next meeting is the 25th of June at 2 o'clock. Thank you all so much for your attendance and involvement today, and safe journeys. Thank you.
Can we stop the live stream, please, John?
Thanks, Kim.